medical director of Orchid IVF Clinic, Dubai, and he's consultant OBGYN, reproductive endocrinology, and infertility. Dr. Dimitrios did his training in medical school and OBGYN residency in Dimitrios University of Thrace, Greece. He did his master's degree in prenatal genetics and fetal medicine, University College London. And he worked in the most prestigious IVF clinics in Harley Street, London, including ARGC, London Women's Clinic, and New Life Fertility Clinic, assisting couples with complex fertility issues like recurrent pregnancy loss and recurrent IVF failures. He joined Orchid, which was founded in 2015, and under his guidance, it's grown to be the clinic with the highest pregnancy rate in the GCC and one of the best clinics in the world with high pregnancy rates and high baby live birth rate. So helping couples with many problems and without exceptions. And today, he will talk to us in a very important subject, which we are seeing in every day in our clinic, about recurrent pregnancy loss updates 2025, the role of the IVF with PGTA. The floor is yours, Doctor. Please.
Thank you. Thank you. Can you hear me well?
Yes, we can see you very well.
Excellent. Excellent. Thank you very much. So, as I said earlier, it's a big pleasure and honor to be here, and I accepted the invitation immediately. Please don't hesitate to call me in any future meetings if you like the presentation today. As you said in the introduction, we started our current clinic in 2015. I'm not the owner. I'm the medical director. I'm not the owner. We got our license November 16. Since then, we have been growing every year. And I put the team there in the picture with the Burj Khalifa because we wouldn't be able to do anything without our amazing team. And most of them actually have been the same since we opened. It's a very strong team. Now, we are really, really proud of our pregnancy rates. The pregnancy rates, I will show this slide with pride, because these numbers that you see are not fake. They are real, meaning, as I say here, I saw here in the yellow boxes, they are not only the good couple selected, and then we say we are good. These are all ages, no selection of good couples, severe endometriosis, severe adenomyosis, surgically retrieved sperms, all the tough couple. Of course, all doctors face low ovarian reserve and women coming to get their first baby at 43 and 44 and 45. All these women are here. So this is per one embryo transfer. We only transfer one embryo because we have the luxury of the PGTA. So we're very proud of these results, and we hope for even better in the next years to come. I put this slide there for recurrent pregnancy loss because I put it in a nice way, not to show us what, as gynecologists, we don't know, but to show us how we can get help, that we are not alone. And I will show this slide again at the end, because I want this to be the take-home message from today's talk. And this is not me saying only that we're not alone. If you actually, I know for a gynecologist and obstetrician, it's difficult to know all these things. Even us, that we do genetics, it's so difficult to do all these tests. They're so expensive. They're so complicated. But keep asking for help. For example, I'll give you some example. There's no way any of us can know the cutoff of anti-TPO antibodies above which a miscarriage is happening, but the endocrinologists know. There's no way for any of us to know, for hematology, all the clotting cataract, and if one high factor 5 can cause a miscarriage. but let's ask our hematologists. There's no way any of us can know about any anti-nuclear antibody or any anti-Rho like antibodies if they can cause a miscarriage. But let's work together with our rheumatologist or immunologist. And the same goes about the varicose veins, the same goes about the sperm DNA fragmentation, the same goes about a very small translocation that you may pick up in the karyotype. Let's work together. That's the take-home message from today. Please keep that one, especially for the general obs-and-gynae doctors who are listening to us and they see a couple with 2-3 miscarriages. Think, how can I get help from my other colleagues? Like, if you suspect the uterus might be a little bit of abnormal shape, get an MRI from your friends, the radiologist. That's the take-home message from today. I always put this slide there in my presentations because I say I come from the most beautiful city in Greece. I know all of you know Mykonos and Santorini, but this is the most beautiful city in Greece at the north. And it's the city that Philip and Alexander the Great, not so much Alexander, but Philip made my hometown back before Jesus was born. And this is how it looks now. The actual building you can see in the pink here is my high school. And I put this slide there to show you that although Alexander the Great had zero fear, and I should have been like also fearless coming from that area to be able to apply all the treatments immediately, like put all the add-ons. I don't. I'm very, very scared, and we should be scared to add new things to women with miscarriages, because we are the only specialty, fertility and IVF, and gynecologists also, who deal with 3 people, 3 patients, the only specialty in medicine. We deal with the mom and her eggs and her uterus. We deal with the father and the sperm and the DNA of the sperm, and we deal with the embryo. So and the genetic anomalies for the embryo. So our job is complicated. And I put this slide there to show you my initial interest from back 2011 in UCL. This was my dissertation project. And this poster was the first ever, at least in the European level, to be published in ESRE in the conference in 2014 from me when I was in London Women's Clinic. And that shows you my initial interest from back then on the immunology. All of us know that if we have a normal embryo and we prepare the uterus in a nice way in the body, we should get a baby. The most difficult part is the normal embryo. We didn't know this in the past, but now that we have genetic testing of the embryos, we realize that everything that we had been telling women in the past with miscarriages, or your immune system, or your body, or rejecting the embryos, your HLA typing, this is secondary. Not zero, of course, but secondary. The main thing is, let's get normal embryos first. And look here, I put this slide because it's very interesting. Let's say you have a woman in front of you with miscarriages and a very low AMH, but she's 35. She has a better chance for a euploid embryo and a baby than a woman over 42 with a high AMH. So this is something I want you to remember. Don't worry so much if the woman is young with low AMH. Eventually, we will get good eggs from her. And then I will start with the ESRE guideline that says we shouldn't be doing PGTA for couples with recurrent miscarriages. And I will try to show you how the evidence now is for the opposite. But look, if you look into the guideline, all the studies are very old. The studies are very old. And the good thing about ESRE, slowly, they're realizing their mistakes, not only on recurrent pregnancy loss, but in other areas as well. And they're updating faster and faster. They're not so fixed like they used to be. So I'm expecting more updates soon. And then When I was in Rome last year, I saw this fantastic sculpture in the church, and you cannot see this, but this is one of the saints, and people are actually taking the stones to stone her, to kill her because of her beliefs. And this brings my thoughts to many of the doctors who were pioneers, including Professor Nicolaides, who were told at the beginning that they were charlatans, that they were clowns, that what they were doing there, it was not medical. And then, of course, after a few years, everybody is following their advice. So don't be afraid to think outside the box. Don't be afraid. Of course, none of us can be a genius like Professor, at least not me, but because he is a real genius. But be positive about things that they can help you help the couples. So can we use IVF and PGTA to prevent miscarriages? The answer is yes, we can. Why? Because most of the miscarriages are caused by genetic problems of the embryos. That is now true. We know this. And can we do it with PGTA, with the biopsy? But now I will show you that we also have ways to know about the embryos without touching them, just by taking the fluid around the embryos while we do IVF. I am sure you all know that now we have every baby has a camera on top when it grows in the lab, and then a camera looking at you 24/7. What does it remind you of? The big brother. And this is how it looks, but it helps us understand so many things about the development of the embryos and which embryos are going to make normal euploid healthy babies. And then when we reach to day 5, the blastocyst stage, in the past we used to only do the method on the left, where you used to pull some cells from the early placenta, the trophectoderm. But now we are doing more the method on the right. The embryologists, they are sucking a few cells, and they do a quick flick and detach the cells from the embryo, rather than burning with the laser that you're going to see in the method of the right. They're doing comparative studies, and those studies are showing so and so difference, but most of the embryologists actually, they prefer now the method on the right, the flicking. This is like the latest methods. There you can see the laser on the left. So just to show you that things are moving forward. Now, this is a slide that when it came out, it was revolutionary study. This study was saying, well, doctors, stop thinking about checking the uterus, stop thinking about checking the thickness of the lining, stop thinking about giving heparin for thrombophilia, stop doing hysteroscopies, just get normal embryos, and if it keeps failing, you keep transferring, and eventually you're going to get your baby. This is partly true. I always want to show this slide to tell you how important the normal embryos are. But after that, another study came to say, actually, if I have 5 genetically normal embryos, 95 to 98%, I'm getting a baby. Also, I hear that, we hear that, we believe that. But here comes 2 questions. How many couples are going to have 5 blastocyst euploid? To get 5 euploid blastocysts, you might have to start with like 30, 40 eggs for some ages. And second point, if 1 or 2 blastocysts fail, you shouldn't initiate some extra investigations. All of them have to fail to start investigating. I put this slide there for doctors who see couples with recurrent miscarriages and say, let's do a karyotype for the man and the woman to see if it's 46XX and 46XY. The chances are that this karyotype will come back normal. So in a setting with low resources, I'd recommend skip this test. Leave it for last, because most likely it's going to be a waste of the time and money of the couple. To give you an idea how difficult it is to get euploid embryos, especially if there is another condition report, I'll give you our publication from last year. It's actually less than a year ago. We were the first to report this delivery of a healthy baby boy with this free of this genetic condition, because the couple knew they had a previous miscarriage with a baby with a problem, and then eventually we managed to give them one healthy boy without the baby with the one, and now they are pregnant. I think they're about to deliver their second baby, which is a girl without the condition, and they're very happy about it. But look, we had to get 56 eggs to get 2 normal embryos. And here is what I was talking about. This is only a few months ago published, that says actually when a couple has unexplained miscarriages and they do PGTA, it increases the pregnancy rate, the baby rates, and reduces the miscarriage rates, because the doctors who go against PGTA, they say there's no evidence to support. Actually, the evidence is emerging. You just need to make the studies, to organize the studies properly, because it's such a multifactorial condition, the miscarriage. So another question we get, but doctor, you want to do PGTA to test the embryos. Aren't you going to damage them? The answer is maybe yes. There are studies that say yes. There are studies that say no. We believe that there is a small damage to the embryo. What does damage mean? It means that an embryo that is normal, in order for us to know that it's normal, to damage the trophectoderm so much that it will not implant. So in reality, we lose one good embryo just to know that it's a good one. So is there any way around that? Yes. As I mentioned, we can measure, we can take these droplets of fluid from the spent media, as they call it, and put them in an analyzer and see. Now, we have been part of this study since 2020, and we are working together with iGenomics. Actually, ORCID is one of the chosen labs, the only lab in the GCC that has been chosen to participate on this study, because we are so strict with our protocols. And now we're going to the second level of this non-invasive genetic testing. I believe that in the next few years, the non-invasive genetic testing, together with artificial intelligence on the embryoscope, will be able to help us predict or find the euploid embryos very accurately as the biopsy. But that's just me. Maybe I'll be wrong. Just telling you that this is Dr. Maria, our previous lab director. In every major conference we have published on this, and our publications got accepted. Even she was part of the group that published infertility sterility with Carlos Simon, Denis Sakas, and Carmen Rubio, and still here in the latest European conference on genetics, she was there introducing. Back to our recurrent miscarriages. I urge you, the gynecologist, on top of speaking to the specialists, to have a high suspicion rate for things that could have been wrong. And I put this picture there. Look at this beautiful uterus. Anybody would say is amazing. Why will this woman have unexplained infertility or recurrent miscarriage? This is a real case, one of my cases. But then you see the kidney in the pelvis. Then you think, what comes together with a kidney in the wrong anatomical position? You see the abdominal scan didn't reveal much, but if you try the 3D, it shows you a unicornate uterus, which explains the couple's difficulty to conceive and miscarriages. And speaking with Professor Attilio, which I will tell you, he's a member of our clinic, the doctors now, especially in Italy, they're trying to identify the criteria for us to know which uterus actually can accept the baby in terms of the shape, the morphology, and which one needs metroplasty. So you see here, they put this new 3D ultrasound diagnostic criteria. as with any criteria, slowly, we will shape them, we will sculpture them, and find the important ones. But in general, what we say now is that when you see a woman's uterus being T-shaped or Y-shaped, or even little bit of septum, because it's impossible to actually organize proper studies with euploid embryos because these conditions are so rare, it's better to actually try to do a metroplasty the best way you possibly can, and the studies are going to back you up, because in the reality, because this woman eventually she's going to have a baby if you correct the uterus, provided she has normal embryos. We just don't have the studies to back it up. We will eventually, but it works. It works. The same goes for the DNA fragmentation of the sperm. We know that and there's big studies on that now, that when a man is drinking, smoking, has varicocele, then his wife will miscarry more. When he stops smoking, he stops drinking, and we repair the varicocele, then they have a higher chance of a baby to go to term. So the take-home message: never say to a man that his woman is miscarrying 2, 3, 4 times, oh, she's pregnant, so the sperm doesn't matter. It matters. High fragmentation can cause miscarriage. It's out there in the studies. We just don't pay enough attention. 0 alcohol, 0 smoking, lots of antioxidants, and many couples actually have good chances for a baby, even naturally. I put this slide there because this is something that, unless you're into IVF, probably you wouldn't know. Again, this is a real case of a couple. They now have their babies, but look at this beautiful endometrium. I get every time I speak in the conference about hysteroscopy before the embryo transfer, someone will ask me, where is the evidence? Where is the evidence? The truth is that we're not able to produce the evidence so easily. And if I show you this picture, 10 out of 10 of us will say this is the perfect endometrium to do an embryo transfer. But look, it's not the perfect endometrium. We needed antibiotics. And then after antibiotics, we got the twins we needed. The same goes with this endometrium. We see this, we will say, this is a normal uterus, a couple of glands there, not a problem. But these are signs of adenomyosis, focal adenomyosis, and things could be hiding under the surface. So there's no way we would have seen this without the hysteroscopy. And we published this with Professor Attilio. Actually, it was this year. And I have to pay a tribute to him, because this study that says that 20-30% we're going to find unexpected findings, especially if the couple have endometriosis, then correlates with the uterus picture. Always keep that in mind. If I'm not saying push for hysteroscopy, but have a lower threshold when a couple has miscarriages to check the uterus. You don't know what you may find. Even in our clinic, we have the very thin cameras of 2.9 or 4 millimeters. We do office hysteroscopy. Now there's a lot of companies offering office hysteroscopy solutions without even needing the anesthetic. So as I said, you don't know what you will find. And I put this video there because this couple had 10 miscarriages, and right after this procedure, they got their baby naturally, without IVF, without anything. And anybody will say, well, exactly like I showed you in the picture, like, look beneath the surface, look beneath the surface. And you see here, there is an adenomyoma, a focal one, hiding. And it's so easy to drain it. You will see now the old blood draining out as we put the camera inside. This is not me, this is Professor Attilio doing, but it's in our clinic. In our clinic, because he comes and operates sometimes with us. You see here. If you ask me the exact mechanism that this gland has been causing miscarriages, I don't know. Nobody does. Eventually, we'll probably know when we start measuring the contractions of the uterus and the immunological. But what we know is that after this, we got our baby. Now, regarding the add-ons and the add-on therapies, this study I always present because it's one of the biggest studies from England, and you know how the English are difficult to add extras. What it says is they took women that 30,000 of them that failed the first baby and the first embryo transfer. And then they added the extras with their second or third best embryos, and they succeeded to have a baby with the worst embryos. This tells you something about the add-ons. Then there's nothing wrong to give. Talking about heparin plus aspirin, probably you all know this, and it's one of your first-line treatments after the first miscarriage. And it should be, because it doesn't do harm. In Dubai, we have the luxury of having doctors like Dr. Bhavna to help us not only with the testing for immunology, but also the treatment, because it's not easy for just a gynecologist to ask to start treatments like this. I don't know if any of you are using immunological treatments apart of a little bit of glucocorticosteroids like prednisolone, but with an immunologist by your side, you can take it to the next level. For example, I would never dare to give hydroxychloroquine, but we've been giving now for 10 years with some good results. Is it safe? Yes, it is. I'm putting there some studies to tell you that it's not only us. Around the world, for many years, doctors have been using. How do we use it? We start 1 month or 2 months before the frozen cycle. If it's a natural conception, you can start immediately and ask the couple to keep trying. Gradually, we increase the dose, and with the help of the doctor, you can even measure the levels in the blood and tailor them, like for personalized medicine. Side effects are rare. They're not common, and when they come, we stop the drug, they subside. And at 12 weeks of pregnancy, we can stop it, or we can continue all the way to the end. One, like talking about cytokines Th1 and Th2, again, it needs a specialist to test and interpret. And this is the test that we do by sending the bloods in the US, but actually now to the lab in Chicago that invented this concept 30, 40 years ago, but you don't have to. Any lab that can accurately measure TFN and TNF and IFN and their percentages can work. And then I put this slide there because very few people know about this experiment, but in reality, it says that if we increase the TNF in monkeys and in mice, then artificially, then they develop preeclampsia. And then we know that we have anti-TNFs that work and they're safe for pregnancy. So it helps with the implantation and it helps with the pregnancy growing well. We cannot give this so easily as gynecologists, but with the help of an immunologist, we can. And if the insurance is private, then then having an immunologist on board will help they will help the insurance accept all that. The same goes with tacrolimus, which we all know that we use it for kidney transplant or liver transplant, but actually it works well for miscarriages as well. And if you actually put it on PubMed, you will see there's plenty of publications for miscarriages and tacrolimus and women having their babies. And then look at the Japanese registry. They just published 2 years ago, and they saw that in women who needed tacrolimus, it's not causing birth defects more than the general population. So it's considered safe. Look at the sample size. Another study between 2 years, women with recurrent implantation failure. This is not with genetically normal embryos, but look at the difference. 60% got baby with tacrolimus and 0% without treatment. And they use the same lab to measure as the one that we use in Chicago. It's a huge difference and statistically significant. How does it work for IVF, for the recurrent pregnancy loss tacrolimus? It has probably to do with the progesterone receptors in the uterus. This is how it works. It helps the uterus not to work in an environment where the progesterone receptors are blocked. So once this problem is not there, then the uterus stops contracting irregularly, and all the progesterone we give from the outside is actually helping the uterus accept the baby. Again, the take-home message: ask for help. Don't think you're alone. Don't think that it's only you and you know very little about this. Ask the couple to wait. Speak to your friends. Speak to your colleagues, and get back to them. I put this slide there from Socrates because many of you know from your school years that he never used to give the answer straight to his students. He wanted them. He asked them the right questions. That was his wisdom, that he always asked the questions that couldn't have another answer apart from the truth. And this is how he got all his glory. And it comes now, his major saying that actually we don't know how much, the only thing we know is how little we know, comes even in a t-shirt in Amazon for any of you who are interested. So I believe now, with everything that you know, you would start, if you have the capacity, with PGTA, and then add the add-ons for couples with recurrent pregnancy loss. And this is a guideline how to go through. Check for immunology, check for thrombophilia. If the couple are over 35, think genetics more than anything else. Genetic is their problem. That's why they're miscarrying. And if one normal embryo fails to implant, start investigating. Think, am I missing some adenomyosis, some endometriosis? Am I missing something in the shape of the uterus? Some hidden polyp or fibroid or chronic endometritis? These are things that you can easily exclude. And this is our promise to all our patients, that we will always be trying for the best, like all of you, I'm sure. And thank you. I hope I didn't bore you too much, and I hope it was interesting. Thank you very much for listening to me.
Thank you very much, Dr. Dimitrios. It was very interesting and very comprehensive lecture. And we can now, any of you can write a question or can open the mic and ask Dr. Dimitrios directly. I can start myself asking two questions. First, when we can, those who can get pregnant naturally and have recurrent abortion, when shall we go to IVF and PGTA? After how many abortions? This is my first question. And if you want to answer,
I can answer this, and then you can move to the second question. The answer is over 35.
Dr. Dimitrios? شكله في مشكلة في الإنترنت عند الدكتور. We cannot hear you, doctor. Please check the internet at your side. إذا حدا من الزملاء بدنا نحضر أسئلة عبين ما يرجع الدكتور، تقدروا تحكوهم حتى بالعربي ونحضر له إياهم. إن شاء الله بعود برجع معنا. شكله انقطع الإنترنت عنده.
يعطيك
حدا
العافية
بيحب؟
دكتورة سحر، كيفك؟
هلا دكتورة غصون، كيف حالك؟
حبيبتي الله يعطيكم العافية يا رب. بس حبيت أسأل إنه بناء إنه هو بيحكي إنه نعمل هيستروسكوبي prior to IVF يعني تقريبا to every patient، يعني is it logic؟ يعني
هو بيحكي على recurrent failures، هو بيحكي على recurrent pregnancy failures، إنه نروح نعمل هيستروسكوبي، مش the first one. هي
يعني
المحاضرة
هو
على recurrent.
يعني إنه أكتر من مرتين ولا أكتر من 3؟
هذا اللي كنا بدنا نسأله، إنه إمتى اللي عندهم أبورشن إن شاء الله بعود يرجع هلا.
وكمان السؤال انه هو بيحكي انه ممكن انه نعطي الادجوفنس او الادس اون، انه يعني بشكل عام لاي حدا عنده سيستماتيك إلنس، يعني مثلا اي حدا عنده مشخص اوتو اميون انه احنا نعطيه من البدايه مثلا البلاكونيل او الهيدروكلور، هذا اللي هو البلاكونيل او ما شابه، او انه احنا نعطيهم مثلا كورتيزون او هيك. يعني ما فيش بالضبط، خلينا نحكي انديكيشنز واضحه.
هلا هو حكى في عندهم الاميونولوجيست اللي هي هاي الدكتوره اللي احنا راح تعملنا محاضره طلبنا منها، هي رجع الدكتور.
I'm here, sorry.
Welcome back Dr. Dimitrios.
The internet somehow just stopped here in the
No
hospital.
problem.
I'm sorry.
No problem.
So
we have couple of questions also, and please shall I repeat my question, the first question?
I will tell you, I remember. So I was
Yes.
telling, if the lady is over 35 and her AMH is low, there's nothing wrong to start discussing, well, keep trying, but if it happens again, go for the PGTA. Of course, if you have the facilities. So this is the cutoff. In general, even in the US, that, of course, you know, PGTA is more let's say, established. The doctors have the cutoff of 35 to discuss PGTA. This is the answer. Even after one miscarriage, you can discuss with her. Some couples cannot even handle the psychological burden of one miscarriage. They say, Doc, I'm not getting pregnant again until you tell me the embryo you're putting in is normal.
Okay, this is very important. My second question is, like, I have a patient, she is 25 years old. With primary infertility and the male factor mainly, but she has high FSH and low AMH. How can we deal with the normal AMH? Sorry, the AMH is normal and FSH is high, like 18 and 19. So how to deal with her regarding the AMH or regarding the FSH?
Look, more than anything, try to deal with the sperms. Don't neglect. Investigate. They're both so young, so probably either the husband is smoking very heavily, or he has varicocele, or he's working in a toxic environment. Let's say he has a job with chemicals, with fumes, all of that. All this is reversible, easily reversible. We move now from the way that we said, oh, let's do ICSI, ICSI will find the best sperms. No, the IVF success rates are definitely lower if we don't fix the sperms. So that's the first. Second, yes, they need to hurry up. This is what the FSH is telling you. Hurry up. She's only 25. She has 3 months for them to improve the sperms. And usually what you see in these women is that actually 1 month, she might have FSH 19, but the second month, she will recruit more follicles. She will have an FSH of 10 with good estradiol and a good antral follicular count. So there you can think, okay, I will do an IVF for her mainly to bank some embryos to make her fertility better, because we don't know how this AMH will be in the next year or year after, or how the FSH, so you can't just send them home. But first, improve the sperm. Second, do IVF with better sperm, mainly to freeze some embryos. And then slowly, when your embryos are frozen, of course, she's 25. Most likely, she will not need PGTA. Nobody would dare advise PGTA unless the couple really want it. So this is the advice for a couple like this. think faster, but don't neglect the male factor. Whenever you see male factor, you must work towards it with vitamins, with seeing an andrologist, checking how much he's smoking, and about the varicocele and the environment.
Thank you, doctor. There is Dr. Ghussoon Badran. Dr. Ghussoon, please, can you say your question? She was telling if we have like the failure of first IVF, shall we
Yes.
go directly to do hysteroscopy? Dr. Ghussoon, are you with us?
Yes. Please, doctor, can you tell us when we consider the case is having recurrent implantation failure after 2 or 3 or more, and when shall we go for diagnostic hysteroscopy, even we can see triple line endometrium or no clear pathology?
Yeah. Look, for me, and again, this is for me, like I've seen so many abnormalities. Like I said in the study I presented, 30% of normal scans with recurrent miscarriages will find you something. You will find something that you were not thinking you were going to find. Again, starting from an abnormal shape of the uterus, where you have a bigger arcuate uterus or a bigger septum that you were thinking. You said, she has a little heart-shaped uterus. You do in the scan, you do the hysteroscopy, and you see the fundus covering almost the whole cavity with a little bit of metroplasty to the fundus and the right and left. Immediately you make this woman's chances better. And again, the fact that we don't have the studies yet doesn't mean, you see how they're making the criteria, doesn't mean that if you do this, you're going to do harm. That's one. Number two, chronic endometritis. Number three, a very tight internal os that maybe the IVF is not working because of that. Number four, like I said, anomalies like unicornate uterus that nobody picked up in the scan. So, and then of course, focal adenomyosis, like I showed you the video. There are so many things that you can pick up just by doing a quick, even office hysteroscopy. So I'm a big fan of hysteroscopy.
Thank you.
Also,
yes.
Yes, please.
Sorry, doctor.
Dr. Ghussoon.
Yes. Can you please tell us when to give like Plaquenil or these autoimmune medications? Any patient has any systematic illness or autoimmune, should we offer them either corticosteroid or autoimmune medications?
This is easy. And the same like that, that's why I put there the slide of how scared I am. I should be less scared, but meaning that, yes, to give 10 milligrams or even 20 milligrams of prednisolone, the studies are there to help us. Nobody will say, oh, if something goes wrong, why did you give? Because for now 40 years, we've been giving prednisolone for recurrent pregnancy loss and dexamethasone. But to go to the next level, to say to this woman, take the Plaquenil, take the tacrolimus, take the Humira, you cannot do it as an obs-gynae yet. You don't have, first of all, you need a full test of the immunology. And we don't know what test to ask for. The rheumatologists do know that. So ask for help. Then the results will come back. We don't even know how to interpret how if an ANA pattern is affecting the woman's chances or not. Even sometimes the immunologist cannot tell you if this is directly related, but what they can do is they can say, based on these immunological results, I am recommending these 2 milligrams of tacrolimus to start close to the embryo transfer or immediately after the next pregnancy, because hydroxychloroquine needs 4 to 8 weeks to work and is not even an immunosuppressant, it's an immunomodulator. So the immunologists give it like this, they don't mind so much. The tacrolimus is a bit of a stronger drug, and the Humira even stronger than that. So you need some support as a gynecologist. You cannot prescribe this on your own. If something goes wrong, and all these drugs have side effects, we will be in trouble. We will be in trouble. The couple will come and say, doctor, why? You didn't know about this. Where is the evidence? But if we have the immunologist to back it up and say, well, this was her result and I gave her this, then we are in the good. We are helping.
Thank you, doctor. Should we continue giving prednisolone 20 all over all her pregnancy, or should we start tapering the dose after 1 month or like this?
3, the first trimester. After 12 weeks, we can safely taper. We can safely taper. If there is I always say, if there is a case of second trimester miscarriage, then it's a different story. If a baby stopped at 20 weeks or 24 weeks and we can't find the reason, there was no genetic anomaly, then nobody can blame us if we continue. Of course, aspirin, we now continue up to the end, but like heparin to go beyond the second trimester and prednisolone to go beyond the second trimester, we are justified to do that. Just like what you do when you have, God forbid, a stillbirth. Then the second pregnancy, you continue the heparin all the way to the end, correct?
Yes, thank you very much.
Doctor, we have 2 questions in the chat below. First question of our colleagues who entered a bit late, he said, PGTA improve live birth rates or reduce miscarriage rates in couple with recurrent pregnancy loss?
The answer is yes, the evidence is emerging. And that's why I saw that study from 2025, January. The evidence, if it's a well-organized study with every other parameter like taken care of, then the answer is yes. Eventually, we will get the evidence we need. For now, my answer is yes. PGTA is reducing the risk of recurrent pregnancy loss.
Another question, Dr. Bashar, he's asking you if you recommend endometrial scratching after performing the hysteroscopy.
Yeah, the answer is I don't believe it helps, but I do it. I don't believe it is the only factor. All of us have seen. I did the scratching and she fell pregnant. I did the metroplasty and she fell pregnant. I don't believe, of course, the studies, you probably read them now, they say there's no difference, but I still do it because it doesn't do harm. But very, very mild, only with the scope, little bit of scraping in the fundus, the left, the right, and little bit the top and bottom, and that's it. Nothing very vigorous,
Any other questions?
Dr. Sahar?
Yes, Dr. Hisham, please.
Good evening, everyone. Thank you, doctor, for your interesting lecture. I have a couple of questions, actually. Number one, we come across some women, young women, who have regular periods with normal FSH, but they have a poor ovarian response. And they have a low, very low AMH. So what do you advise these women to do for getting pregnancy? That first question.
Yeah.
Second question, what's about women who have a high FSH, poor ovarian response? What do you think about the injection of PRP, platelets, directly into the ovaries laparoscopically? Thank you.
Yeah. The first question is a tough one. The answer is what I always say about low AMH. The answer is hurry up. Whatever you do, hurry up. Don't let the couple go home and say, come back after 6 months. No, check them every month. Do IUIs, improve the sperms, keep pushing with all the extras. Don't, because if they come to you after 1 year of not being pregnant or having one miscarriage, then the AMH will be half of what it was last year. So hurry up. And if they come and tell you, doc, we want to go straight to IVF for embryo banking, so to put some embryos in the freezer, I wouldn't say no. provided the AMH is very low and we check the other parameters. So this is my answer, because we can't do much about these couples. The PRP, I am doing in my clinic, not very fanatically, because like you, I'm also waiting to see if it's actually working. I haven't seen miracles. Other clinics are raving about it, that, oh, it makes a big difference, and the woman with a low response to IVF, few eggs, suddenly she got many eggs. Yes, but remember that we see better response in the second or third IVF cycle sometimes anyway, because of the puncture, the injury of the needle to the ovary. The second, the third, or sometimes even our medication, the ovaries wake up and we see more follicles the second or the third time. So the answer is, I'm not against PRP. I'm waiting to see. I'm waiting to see.
Right. Thank you.
Do we have any other questions? I put the feedback link, so if you want to fill, so if you need a certificate of this lecture, and we'll be having the immunologist, the doctor you told us about, she will give us a lecture in July, hopefully.
Excellent. Dr.
So
Bhavna,
we know
she's
about
excellent. She's excellent.
Lastly, hydroquinone, like Plaquenil, it's can we use it without many tests? Because we have like low socioeconomic
I know.
level.
I will let Dr. Bhavna answer that. I will let her answer that, because it's cheap. It's an easy drug. It doesn't have side effects. It's not even immunosuppressant, as I said. It's immunomodulatory. So it takes long to work. It doesn't work like this. It takes weeks. But I will let her. She's the expert. She's the expert. I was
Then
even
we will-
giving since London, since 2011, but UK is different. In the UK, the law allows you to prescribe any medication you want, as long as you are sure that you are helping the patient. For example, in Dubai or the US or even in Greece, you're not allowed. You have to have, only the specialist can prescribe a specialist drug. I cannot prescribe Humira, for example. I'm not allowed. And then if the side effect happens, I will be liable. But in a low resource setting like yours, I believe we will do no harm. But of course, always, like, you can start it and then tell her, well, why don't you go and see the doctor, also run some tests, or get the green light also.
Thank you so much, doctor. It was a very important and high quality lecture.
Thank you.
For your time. We're
That's
pleased to
kind
have
of
you,
you.
and we hope that if we have the situation suitable for the conference in October, that we will have you in person. Thank you so
It
much.
will be my pleasure. It will be my
And
pleasure.
thank you.
All the best to everyone.
Good night. Thank you so much,
Bye-bye.
doctor.
Take care. I
Thank
hope
you.
everything finishes soon over there. Bye-bye. Bye.
Bye-bye. Bye-bye.